عليكم السلام. أهلا دكتور.
شلونكم عيني؟ إن شاء الله زينين. صوتي واضح؟
نعم دكتور واضح.
السلايدات تشوفوها؟
أي نعم دكتور.
هسه واضحة؟
إي دكتور طالع سلايد شير.
ماشي. اوكي فاين. بسم الله الرحمن الرحيم. This is the first lecture. بس لحظة خلي أسجل. نسيت. Okay. This is the first lecture of a series of neurology and neurosurgery lectures. The first lecture is approach to the patient with neurological diseases. For neurological assessment in general, we must be step-by-step clinical methodology that does not fail. Maybe the word maybe not fail is an extreme, but it refers to or pay attention for a methodology that is obligatory to be done for any patient with neurological problem. The first step involves gathering of information. For anything in general, before we can say anything about any subject, we should gather information. In other words, establishing the database. The tool for gathering information and do a database for any neurological patient is history and examination. So evaluate any patient is by history and examination. So what is the rule for investigation? In neurology, we use electrodiagnostic testing, in neuroimaging, and laboratory investigation. These testing should be used an extension, and definitely an extension, and not a substitute anyhow for taking good history and do proper neurological examination. It's used to confirm the neurological problem and exclude other possibilities. In general, our aim in approaching a patient with a neurological disease should be not content to neurology, diagnosis. Also, not limited to giving a treatment, but there should be a clinical problem solving. And for clinical problems solving, typically 4 distinct steps that should be undertaken to systematically solve most clinical problems. The first step, the most important step, is making the diagnosis.
عفوا دكتور.
عيني.
بس السلايد شير بقى على اول سلايد. ما عرفت تحركت، يعني قاعد تحرك بالسلايدات ولا لا؟
انا قاعد اتحرك من زمان.
دكتور اذا مسوي فول سكرين فما تتحرك السلايدات عندنا.
انا فول سكرين مسوي.
اي دكتور أوكي. هاي مشكله صارت وياي. اي
هسه
دكتور هسه تحركت.
اوكي هاي للكل لو بس الك، بس خلي اسمع من البقيه.
دكتور للكل هاي انا هم
للكل. يعني ابقي بهالطريقه على الحكي.
اي نعم بقي.
فاين، ماشي يعني ماشي. اوكي. The first step is making the diagnosis. Maybe it is the most crucial step, but it's not the only step. The second step is categorizing the disease. What do you mean by categorizing the disease? Assessing the type, stage, and severity of the disease. Many examples have multiple sclerosis, myasthenia gravis, Parkinson, migraine. The treatment depends on either the type or the stage or the severity of the disease. And sometimes the prognosis depends on the type, stage, and severity of the disease. So we should categorize neurological diseases. The third step is best proper therapy. Once there is likely etiology, a treatment plan can be formulated. I know, honestly, that any doctor give the best proper therapy according to his diagnosis. Maybe it is wrong, but he will give the best proper therapy. But what I mean in best proper therapy, something else. It is best to give therapy to active problem of the disease, because many patients can be present with many problems. But the active problem, what make him seek medical advice, should be treated. Patient with migraine. In investigation, we found the patient have hyperlipidemia. The active problem is migraine. He's in pain. I don't say hyperlipidemia is not important. It's very important, but we can deal with hyperlipidemia later on. We give best proper treatment for the active problem, active disease, rather than all what the patient have. The fourth step, and very important step, is follow-up. Following the patient response to treatment. Sometimes we revisit the differential diagnosis and maybe change the diagnosis completely and give another treatment for something else, because the right treatment is different from the first impression by follow-up. So it's not, if we exceed the aim of the approach to clinical problem solving, we should put follow-up one of these steps. Before we start the neurological diagnosis, any question? You can ask any question and give any comment anytime. Don't be hesitate to interrupt me and give your question or your comment. The neurological diagnosis. The diagnosis achieved by carefully evaluating the patient. As we said, we have history and examination. This is the tool for evaluating the patient. Analyze the information. We have the story of the patient, but what is the significant? What is not significant? What is the main? What is the cause? And what is the effect? That is by analyzing the information, because the patient may give us many information. Most probably he doesn't know what is the significance of each one. What we should analyze the information and understanding the cause-effect relationship. According to analyzing information, we can write a possible scenario for the patient illness. And according to the patient scenario, we can developing a list of differential diagnosis. And when we construct a list of differential diagnosis. Now we can start workup to confirm the diagnosis and exclude other possibility. Sometimes these steps intermingled to each other. Analyzing information that is collected by the from the patient on or his relative depend on answering two questions. What is the lesion? What type of the lesion? And where is the lesion? The neurologist, unlike most other physicians, approach the patient from anatomic and physiologic perspective, leaving issue of etiology to be addressed later. So we should have localization of the lesion before addressing the etiology of the problem. Basically, from history alone, it should be possible to hypothesize the nature of the lesion, which explain all the symptoms. When we have a hypothesis of the nature of the lesion, for example, this is vascular lesion, this is neoplastic lesion, this idea explored during an examination and investigation in order to uncover pathological process. So each step in evaluation, his examination. I don't believe in burning steps. حرق المراحل, something unaccepted in general medicine, not only in neurology. What and where may be answered from history alone. If not, where should be answered by examination. But we have two examples, stroke and muscle fiber disease. The question, what is the lesion, is answered by investigation. So sometimes what and where answered by history, but sometimes we need investigation to answer what, but where should be examined by investigation. Examination. What do you mean by what is and where is? What is the lesion? It means the pathophysiological basis of a clinical manifestation. Pathophysiology is very important because make you understand the manifestation. For example, now we live in COVID-19 era. It's very important to understand why the patient with COVID have happy hypoxia. 1 year ago, many colleagues asked me why those patients fall abruptly in the street, especially in China at that time. Nobody know what that happened. Most of the physicians think that it's maybe neurological. But later on, we understand the pathophysiology and understand now why happy hypoxia happened. Simply because they have no dyspnea. So they have low oxygen saturation and they don't feel of that. So later on, they will fall to the ground. Second, the nature of pathological process. What is the nature? The nature of the pathology primarily depends on the temporal profile, and we talk about temporal profile later on. So what is the lesion here? What is the pathophysiological basis of the clinical manifestation, and what is the nature of the pathological process? Where is the lesion is localization of the lesion. Which part of the nervous system is affected? Localization. And if anybody asks me, give me a word synonymous to neurology, I will tell him that localization is synonymous to neurology. Neurology depends on localization. Okay, the analysis depends on answering these two questions. But what is the method to answer these two questions in history? First, define the symptom. We should know the nature and the extent of the deficit. Many patients complain from Dr. أنا دايخ. But what he mean by دايخ? Next lecture, next Wednesday, next Tuesday, I will give you the second lecture, and we will discuss this subject. But we should know what maybe the patient complain of fatigue, and later on we found this is not fatigue. This is not really fatigue. This is weakness. So, and sometimes the reverse. So we should define the symptom and know what is what's really the patient complain from. Mode of onset, determination of temporal profile. This is very important and crucial in neurology, because the nature of the pathology depends on this temporal profile. And temporal profile, they are characteristic temporal profile in neurological diseases: sudden, acute, subacute, and subacute divided in two types: crescendo and relapse remitting, and chronic. So any patient with sudden, what came to my mind, that patient has vascular or traumatic or seizure. When the patient give me a history of relapse remitting course, I instantly think of multiple sclerosis. And if the patient complains from diurnal variation, I will think of myasthenia gravis. The onset depends on، يعني احنا اذا ننتظر كل مريض يقول دكتور على غفله صارت and we call it sudden, this is will be confusing. So, the onset depends on the peak of the severity. For example, sudden onset, we mean the peak of severity at time of onset, and later on either decrease in severity or sometimes be a plateau. It's still the same severity, but the peak of the severity at the time of the onset. And the acute and subacute and chronic, any chronic, there is no peak. No peak. Every day, the condition become worse than the day before. So it depends on the peak of the severity. Variation of the over time, يعني what we call it time course and pattern, either persistent, recurring, improving, or worsening. And so we timeline and evaluate the patient within this time. يعني انت هالاسبوع مثل الاسبوع اللي قبله؟ لا والله دكتور الاسبوع اللي قبله وايد احسن. So it is worsening. اذا لا دكتور والله هي بساعتها كانت قويه بعدين راسا تحسنت. This is improving. Third one is a chronological evolution. If we have headache and fever, it's very important to know which is first and which is second to appear later. If the patient have headache, then fever, I will raise the possibility of subarachnoid hemorrhage. But if fever precedes headache, no. Infection is the top of the list of differential diagnosis. In general, metabolic drug-induced toxin can be presented acute, subacute, or even chronic. But in general, sudden is either vascular, seizure, or trauma. Acute, infectious, or immunological. Subacute, infectious, immunological, and neoplastic. Chronic, degenerative, hereditary, developmental disorder. The third one after temporal profile is evaluate the modifying factor. What make the symptom better or worse? And response to intervention. The fourth point is absent symptom. What we call it important negative. Very important in patient with headache to ask about vomiting, because absence of vomiting is important to at least I cannot say exclude, but to don't make it at the top of the list of differential diagnosis in two conditions: increase intracranial pressure, whatever the cause, and in migraine, because increased intracranial pressure usually associated with vomiting, and migraine usually associated with vomiting. Before starting neurological history, everything is clear? No question? Shall I continue?
دكتور كمل ان شاء الله معك اسئله.
Okay. Neurological history, the most important part in evaluation the patient is neurological is taking history. يعني هسه انا عرفت صف سادس دي يمتحنون بسبب ظروف الكورونا. يعني very difficult to examine them in يعني اليوم كان عندنا يمكن 20 بارحه 20 candidate اليوم 20 candidate. يعني very difficult to examine them on يعني genuine patients, real patients. But we put a simulation to evaluate the skill of taking history. ممكن الاكزامينيشن اوكي رويناهم يشوفون صور كذا يعني بعد التخرج ممكن يتعلمون، لكن taking history is crucial, and this skill should be learned whatever neurological history. And in neurology, neurological history is very important because examination and investigation and most of the patient depend on the finding in the history. Assessing a patient's current symptom is an essential clinical skill. Sometimes the only way in diagnosis of an illness assess the effectiveness of a treatment or formulate a prognosis is only the history. Epilepsy examination usually normal. With EEG, sensitivity is very low. Well, this is the most common neurological disease. يعني 7 بالألف. 5 to 7. So it's incidence very high, and the only tool that we can pick up the patient with epilepsy is history. Physicians know that if they have an hour to spend with a patient, like the final exam before COVID-19 era, then 30 to 40 minutes would often spent in taking history. يعني شوفوا من ساعة 30 to 40 minutes يعني تقريبا 2/3. History of a present illness was give the story of the patient should include detailed description of each symptom, each complaint of the patient, review of other symptom of nervous system impairment. This is in history of present illness, not in systemic review. You should review the symptom of nervous system, other symptom other than the complaint of the patient. The third one, I put it in red, temporal profile. Then hint for localization. And if we have if raised in mind a differential diagnosis, we should have detailed the question which seems relevant to possible differential diagnosis. For example, if we put a provisional diagnosis or a list of differential diagnoses include a systemic disease, we should ask a question related to systemic manifestation if the patient didn't give history like that. Patient with disturbance of consciousness and patient with cognitive impairment, the history usually from the witness, relative, witness in the world, policeman that he bring him to the hospital, whatever. At the conclusion of taking neurological history, the physician should have reached a clear hypothesis regarding the basic type of pathological process. For making proper step-by-step clinical methodology, make list of differential diagnosis after history. يمكن راح تسألون نفسكم okay أو تسألوني for what we put a list of differential diagnosis if the workup will depend on differential diagnosis after doing examination. This is very important. In the first slide, I said we have step-by-step clinical methodology, and to make sure that, but the most important step, which is taking history, done in a proper way, is put a differential diagnosis. زهير قصير الله يرحمه كان هو GIT specialist. قال if you finish taking history without a proper list of differential diagnosis, this is a clear marker that history is wrong أو not enough أو يعني whatever. But definitely this is not proper. This is make you sure that this is step done in proper way. always remember when all else fails take more history. طبعا اللي عندنا ماشي شنو؟ If we didn't reach the diagnosis, do other investigation أو repeat the investigation ونبقى بدوامة وحلقة مفرغة. When all else fails, take more history. ارجع من step by square number 1 and start from history. يجوني مرات مرضى يحط صفطة مع MRI عايدة كل شهر. With each visit to any physician, repeat the MRI, repeat the... مش يطلع لي، ما هو الMRI طلع normal. It means that this illness present with normal MRI. Why do you repeat the investigation? Not repeat the investigation, take history more. Okay. Now we start with neurological examination. يعني أعتقد المجاميع اللي داومت يمنا نيورولوجي يعني 5 مجاميع دامت، يعني أعتقد يعني they have enough information about what is a neurological examination, what is the content of a neurological examination, what's the aim of a neurological examination. But I will pass through this subject rapidly. Neurological examination, answering the question, where is the lesion? There are 4 types of lesion. Either focal, and all the manifestation can be explained in a lesion in focal area. Sometimes it is multifocal, like in multiple sclerosis. We have to diagnose patient with multiple sclerosis, she should have multifocal lesion, cerebellum, for example, and spinal cord, optic nerve in the cerebrum, and brainstem. Multifocal. Sometimes it's diffuse. Diffuse, usually metabolic. Hyponatremia, hypercalcemia, hypothyroidism, hyperthyroidism. The effect will be diffuse. Systemic, it means the neurological manifestation is the reflection of systemic disease rather than a neurological problem primarily, or its complication for systemic illness. Taking history is the first step, and examination started after finishing taking history and put differential diagnosis after history. But this is artificial because sometime, and not sometime, in patient with gait difficulty, abnormal facial expression, and tremor, for example, and speech abnormality can be detected during take history or even before taking history. Patient يجيني ده يجي يدخل علي, I will recognize that the gait is abnormal. When he start giving me the complaint, I will recognize the abnormal facial expression. And in hand shake, we may recognize the tremor, the involuntary movement. When he start to talk, we will recognize the abnormality in speech. And what type of speech abnormality? Is it dysarthria, is it dysphasia, is it dysphonia, whatever. So sometimes the finding of examination precede taking history. Many neurological patients have no abnormal signs, like in seizure. يعني حتى again, if we find abnormal signs, it means signs of the cause rather than to seizure. or simply have physical signs that confirm clinical suspicion based on history. And that's why history is the most important step, and definitely important more than examination. Sometimes from history, we can yield short list of potential sites of the lesion. But in other patients, localization must await for formal examination. This is because for those patients with localization depend on examination, this is because the disease at one site in the nervous system may produce symptom mimicking a lesion at another. There is a manifestation unique for a special area. اللي يمكن يداوموا نيورولوجي يذكرون حكينا على السيربيلم. But motor weakness can be presented from the peripheral nerve to the cortex. So different area in the nervous system can give. So we need examination to differentiate between upper motor neuron and lower motor neuron, and which part of lower motor neuron, if it is lower motor neuron. Localization. As I said, localization, if we ask me about synonymous word for neurology, it will be localization. What do we mean by localization? Localization of the lesion and to a specific part of the nervous system is essential step in evaluating a patient with a neurological manifestation. And with taking history, we search for localization. Sometimes we need examination for localization. And nowadays, with advance of MRI start to give us sometimes, not all the time, precise localization. So localization is in neurology. If we talking about history, about examination, we say something special in neurology, but localization, not something important in neurology. Localization is the neurology, and you can imagine what is localization. Localization is the neurology, not crucial part of neurology. As a definition, localization is identification of which site of the nervous system has been affected. We have these 10 sites of potential this is potential sites of localization. Start from the muscle, then through the neuromuscular junction, peripheral nerve, root and the plexus. Root and plexus, we put it in neurology in the same category because the manifestation is the same. Cerebrum, and cerebrum have cortical and subcortical, and ending in meninges. The discipline of neurology explains the importance of understanding how to correlate the neuroanatomical defect with the clinical manifestation. ليش why the meninges give meningeal irritation signs, why lesion in the cerebrum, the cerebellum, give us manifestation of incoordination. This is the discipline of neurology. In neuroanatomy has two broad aspects. The morphology of the structure راح ناخذ ان شاء الله يعني يعطيكم يا دكتور عبد الكريم المحاضره الجايه. For example, motor system, sensory system, cerebellum. This is the morphology. But what is important is the function. It's a functional representation. because we know the organ by its functional representation. Any area in the nervous system represents itself by its function. The site of the lesion expresses itself by dysfunction. Symptom and sign are the shadow for the neurological dysfunction. أنا أشوف أنا ما أشوف السيربيلم لكن أحس ب because of the sense of coordination. If there is a lesion in the cerebellum, the lesion expresses itself by incoordination. I detect incoordination by symptom and signs, which is the shadow for neurological dysfunction. Functional neuroanatomy provides the roadmap for correct assessment because it is the key for localization in the neuroanatomical map. أنا أعرف الكي الخريطة. I will detect the lesion according to its shadow, the clinical manifestation. As with any map, we need an address intersection. يا إما address عنوان يا إما intersections تقاطعات. address لما أريد اطلع عناوين، هسه تكتبون عناوينكم كذا يسموه أقرب نقطة دالة. شيء مميز يكون يونيك. According to that, we can give me the address of the يعني example. Patient have involuntary movement, chorea, tremor, dystonia. This is address for basal ganglia lesion. ما عندي مكان ثاني يسوي كوريا، ما عندي. كوريا معناها basal ganglia. Signs of incoordination. ما عندي. If we said incoordination, it means cerebellar lesion. Okay. Some type of dysfunction directly give us address we're looking for. Rarely one symptom can give. صعبة إن one symptom can give, but many signs can give مثل ما قلت لكم. So we need a cluster of symptom and sign syndrome for localization. Manifestation of upper motor neuron lesion in one limb. Then give us this collection of manifestation, localize the lesion to this site. One symptom difficult, one sign maybe, but cluster syndrome can give localization of the lesion. Circumscribed lesion in the nervous system cause a group of manifestation classified according to anatomical and pathophysiological consideration. The syndromic and or anatomical diagnosis depend on understanding the pathophysiology of symptom and signs. If I understand what is chorea, I will recognize that chorea must be related to basal ganglia lesion. The syndromic and or anatomical diagnosis with temporal profile taken from history give the etiological differential diagnosis. The immediate linkage of symptom and sign to differential diagnosis is a common approach in internal medicine, in the practice of internal medicine. For neurology, this practice is troubled with hazard and contains the seeds of misdiagnosis. A neuroanatomical diagnosis is required preliminary steps, should be localized. As I said, localization is in neurology. The language of neurology, what I mean in language, not really there is special language, but it means the terminology used and what is referred to. When I said paraplegia, you should know what paraplegia and what is referred to and what give hint for localization. يعني بدل ما أقول there is weakness in the lower limb and I examine the upper limb and there is no weakness in the upper limb, in one word, paraplegia. So this is the language of neurology, which can give directly to the listener what is your impression. Okay, there is a question. نروح على neuropathology. Okay, neuropathology. The neuropathology, in general, neurological disease have two types of classification, either pathogenic or anatomic, and there is no real borderline between both. يعني من نقول demyelination مثلا بالneurology. Actually, we refer to myelin, which is anatomical, and refer to pathology in myelin tissue. So it is pathogenic and anatomic in the same time. There is no borderline between both, but academically, we want to classify pathological insult, sorry. Nervous system disease may be affected particular structure, basal ganglia, cerebellum, peripheral nerve, or one system, motor neuron, and in amyotrophic lateral sclerosis, only affected the motor system, or tissue type, white matter versus gray matter of the brain, myelin versus the axons of peripheral nerve. مريض axonal degeneration، مريض لا يجي demyelination of the peripheral nerve. The anatomy usually imply the etiology. The etiology is the clinical diagnosis. So the pathological profile of the disease is temporal profile, as we said in history, acute, subacute, sudden, acute, subacute, and chronic. Region, part of the nervous system affected, type of the tissue, and sometimes the system, and sometimes tissue type in particular region. يعني axons in the peripheral nerve. A peripheral nerve region, okay, but only the axons. So we cannot diagnose, for example, Guillain-Barré syndrome, which is demyelination in patients with axons affected. This is the type of pathological process in neurological disease. In general, neurological disease be classified as acquired and genetically determined disease. Many types of شوفوا اكو يعني I want to be clear. Hereditary is different from genetically determined disease. Not all hereditary problem is genetically not all genetically determined disease should be hereditary. Maybe due to mutation, and maybe this genetically determined disease need a factor to be shown. For example, many drug-induced need genetically determined, not genetically susceptibility to be happen. So hereditary should be used in special manner. Many type of pathology found genetically susceptible patient, even drug-induced, as I said. Not all the pathologies affected in the same manner. In one manner, sorry, on one wrote. For example, brain tumor. Brain tumor may be a reflection of systemic metastasis, and sometimes many neurological problem a side effect of a treatment of a tumor outside the nervous system. Tumors anywhere ياخذوا من chemotherapy تطلع عندي neurological manifestation, and sometimes يعني يمكن nowadays become rare, but radiotherapy give myelopathy in the past. So it's complication of radiotherapy, not chemotherapy. And there is a neurological problem which is called paraneoplastic. The patient have CA bronchus, and the patient presented with cerebellar ataxia few months and sometime up to a year or two before the presentation of the primary tumor, which is called paraneoplastic syndrome. At the end, we should discuss the neurological differential diagnosis, how we write a list of differential diagnosis. Taking informative history and do a proper neurological examination lead to formation of etiological hypotheses depend on temporal profile, anatomical localization, and understanding the pathogenesis of the diseases. Pathogenesis of the diseases make us understand the cause-effect relationship. يعني ذكر مرة قلت للأستاذ علاء غني، قلت له يعني اتمنى انه بالباثولوجي الميديكال ستوديو understand the pathogenesis يعني much better than to give them the details of the pathology or microscopical pathology, يعني tissue changes. Understanding of pathogenesis is part of understanding the cause-effect relationship. أنا راح أفهم من البرايمري ومن الكومبليكيشن إذا أفهم الباثوجينيسيس of the diseases. These give rise to what we call fundamental equation of differential diagnosis. Differential diagnosis in neurology equal to localization by temporal profile. These two give me the differential diagnosis. It is useful to approach differential diagnosis systematically. خلي system how to write a differential diagnosis so as not to miss an important disease that may be the cause of the patient illness. There are several considerations in constructing the differential diagnosis. First step here, prerequisite approach. If I want to write a list of differential diagnosis, أخلي 5. Which is the most you will say I will put at the top of the list the most likely, but I want you to know that there is different approaches in the world, but I prefer one of them and tell you later why I prefer this one. First one, who a possibilistic approach. Possibilistic approach, it means I will put all the possible causes of this illness. Second, probabilistic. Consider first those disorders that are more likely. ممكن يكون هو migraine, بس this patient the most likely هو الكلاستر. خلي الكلاستر قبل، ما خليهم بالسوى. يجي واحد يقول لي ليش ما ممكن يكون هذا؟ اوكي it is possible but what is the probability of this possibility؟ كل شيء محتمل بس الامكانيه ايش قد؟ هذا امكانيته 10% وهذا امكانيته 90%. اساوي ال 10 وال 90%؟ لا. the most probabilistic approach is more. The C is prognostic approach. Consider the most serious diagnosis. لا يقول لك المفروض تخلي the most serious. هذا ما ينطيك فرصة. الأحسن تخلي the most serious حتى لو كان probability is low. بس لا، شو يقولون pragmatic approach. Consider the diagnosis most responsive to treatment. شنو الفائدة أنا أشخص لي disease هو يعني not treatable. Put the treatable causes first. This is what we found. Prerequisite. I prefer, and most of the physicians prefer, it is appropriate initially to consider differential by probabilistic approach, taking in consideration very common life-threatening treatable entity. During the course of evaluation, this possibility ruled out. يعني أخلي the most probable one and put the most serious and treatable later on to exclude this possibility. Do not forget this possibility. But the list of differential diagnosis يعني in general اكو شيء اسمه rule of 3. لازم عندك ثلاثة يكونون the most probable. خلي الرابع the most serious، خلي الخامس treatable. بس ال priority is for probability. Probability is of great importance for good diagnostician. حتى تحفظ السكيل وتكون professional, you should should be trained on the probability. You should know who is Sir William Osler, واحدة من أيقونات الطب في العالم. Medicine is a science of uncertainty and an art of probability. Medicine is a science of uncertainty and an art هو فن ال probability. So probability is most important for خلينا نتفق. اوكي we have خلينا اتفقنا انه according to probability. Now regarding probable cause, as قلنا probability, one of two routes should be considered in formulation of itemized differential diagnosis. هسه نجي مرحلة itemized differential diagnosis. زين، طريقين عندنا، واحدة من اثنين. Either to one should consider if there is an obvious or very likely diagnosis. مريض بالنهار راح الشغله صاح اخ راسي، ورا فتره فقد الوعي، vomiting، وراها loss of consciousness، ودوه المستشفى بدا يفتح. This is most probably intracerebral hemorrhage. And I will put a list of differential diagnoses of conditions mimic the provisional diagnosis in a way or another. What mimic the intracerebral hemorrhage, I will put it as a differential diagnosis. Secondly, in minority of cases, there is no obvious diagnosis. لا ماكو شيء، ما اقدر اخلي يعني فشي obvious كلهم. In those minority, consider what the patient may symptom and sign and what is the temporal profile. Then construct itemized differential diagnosis by one or more of the following proposal. For example, not for example, this is the proposal way. Consider the patient primary complaint and the weakness. To list potential disorder that affected each possible level of neuroaxis by starting the muscle and moving cranially. إذا هذا المريض الويكنس مالته من المصل، ايش ممكن يكون؟ يا muscle disease يعطيني high temporal